Next up is Dr. Muralidharan C, sir. He's a consultant physician and diabetologist at Vijaya Clinic Diabetes Care Center, Dindigal, Tamil Nadu. And sir will be speaking on the practical aspects of insulin therapy in day-to-day practice.
Thank you for the kind words. Good afternoon. Very happy to see the post-lunch session also, packed halls. I am very happy. Kudos to Dr. Manohar, Vijay Kumar and entire team for this wonderful conference. The given topic is practical aspects of insulin therapy in day-to-day practice. Yes, friends, many of our people, in spite of the perfect good insulin regimen, they experience hyperglycemia, unexplained hypoglycemia, glycemic variability, pain, bruising, development of LH, all those things are happening. So, the important thing is we have to teach, educate them about the practical aspects of insulin therapy, and if they adapt proper insulin injection technique, they can avoid most of the problems. Injection technique is critical in therapeutic success of insulin. Insulin injection site selection is very, very important. Abdomen, upper arm, thigh, etc. Because these areas, people, they have adequate subcutaneous fat, so absorption will be very good, predictable responses will be there. So why do we inject insulin more than one site? So site rotation is very important. We don't find time to educate our patient, our staff. So if we educate and make them to do it, patient will be really achieving the very good glycemic control without the risk of hypoglycemia. So we need to inject insulin more than one site because to prevent the skin thickness, pain and better absorption. See, so you have to rotate the site or zone, and you have to rotate within the site you choose. So this is very, very important. Main important thing is always teach our patients, they have to inspect the injection site before every injection for abscess formation or bruises or bleeding, so many things they have to watch for. So these are all the sites to be avoided. Because some people, they give injection in the calf region, some in the medial aspect of the thigh, some in the forearm. These are all the muscular regions where very little fat is there, and in the medial aspect of the thigh, complex of nerve endings. So these are all the areas to be avoided. So absorption, you all know, the order of the rate of absorption, quick in abdomen, slow in the buttock, arms and thigh in between. So can we change the site daily? No, we need not. Rotate within the site or zone for 7 days, then switch over to opposite side. If a patient is taking one injection per day, either right arm or right thigh for 1 week, then they can change. If the patient is taking 2 injections per day, morning right arm, evening abdomen or right thigh. The patient is taking 3 injections per day, morning right arm, lunch, upper abdomen, dinner right thigh, 1 week, then you can switch over. So these are all the grids available, thigh rotation grid and abdominal grid, which will help the patient to give the injection 1 finger breadth apart. So now many patients, they are reluctant to getting injection because they say that injection is very painful. How to minimize the painful injections? So injections in use should be kept at the room temperature, that is not exceeding 30 degrees Celsius. And this is a double pot method, clay pot method. Put the sand inside and pour water. The water evaporates, pulling the heat from the pot. So you can keep the vials inside. Many patients in the tropical countries, when they don't have the fridge, they can use this method. So skin should be dry before injecting if the injection cleaned with alcohol swab. And injecting into the root hair should be avoided. And needles, nowadays we have 4 mm needle, 5 mm, 6 mm. For the pen users, 4 mm needle, 32 kg is wonderful needle, absolutely painless. Whereas syringes, nowadays it is 6 mm. That is also very useful, painless. They can directly enter into the subcutaneous tissue without the risk of intramuscular injection. And also insulin needle should be inserted at 90 degrees to the skin. And also when the large doses of insulin is needed, then it is considered that splitting of the insulin is ideal. And whenever the patient uses a pen or a syringe, insulin should be injected slowly, and care should be taken to completely depress the thumb button or plunger while injecting. So pinch up or skin fold lifting up. This pinch up or skin fold lifting up is not for the pen users because 4 mm needle, short needle, whereas syringe needle is 6 mm needle. To avoid intramuscular injection, we advise the patient to go for a skin fold lifting up. Correct method is don't use a whole hand. You can use thumb and the forefinger. It should not be squeezed so tightly to cause pain. Insulin storage is very, very important part. In places like Bangalore, the climate is good. In our part, Tamil Nadu, South Tamil Nadu, very hot tropical climate. So the room temperature is around 35 degrees Celsius. Outside temperature is more than 40. So we have to store the insulin below 30 degrees Celsius. Unopened new vials, etc., they should be kept in the fridge, maintained within 2 to 8 degrees Celsius. In general, once the vials are in use, where to keep, where not to keep. Not to store the direct sunlight or hot places, kitchen, etc. And dashboard of the car, you should not keep it. Where to keep it? Fridge 2 to 8 degrees Celsius, not stored in the that is wall of the fridge, door of the fridge. You have to keep it in the middle compartment. Don't keep it in the freezer compartment. To use the insulin, it must be kept out of the fridge for 10 minutes to reach the room temperature to avoid pain, etc. Whereas insulin suspensions, once a clump formation is there, they should be discarded. Here, this is a double butt method. Insulin syringes. Nowadays, in the last 10-15 years in India, we have both the U40 vials and the U100 vials. In abroad, Western countries, only U100 vials are available. There is no problem. One stent, one syringe. Whereas in India, both the U40 and the U100 are available. You have to educate the patient. Whenever you write U40 vials, you mention it is U40. Please write down the syringe, 40U syringes. You tell the patient that you have to match U40 syringe. The syringe, they have to identify, they can see that red cap and red markings on the body of the syringe. Whereas U40 vials, orange cap and black markings, and they have to check. So right way to store insulin. Storage below 0 degrees Celsius may lead to the product being frozen, causing cracking of the vials and cartridges and or displacement of the plunger in the cartridges. So all of which will cause the product to become inhomogeneous and non-sterile. So during the travel, car, bus, train, the insulins can be stored in an insulated bag or cooled thermoflask with ice if the ambient temperature is expected to be higher than 30 degrees Celsius. And also, insulin should not be kept in a locked car with closed windows. And air travel, nowadays it is very common. Insulin should not be placed in the checked-in baggage to avoid exposure to extreme temperature, mostly freezing. And never leave the needle attached to the pen. Many of our patients, they never remove the needle. They leave the needle attached to the pen. What will happen? When it is cold, air bubbles to form in the cartridge, inadequate dosage next time. Whereas in the hot, insulin to leak out of the cartridge. When the insulin is leaking out, what will happen if it is a pre-mixed insulin? Leaking pre-mixed insulin can derange mixture ratio. This can lead to incorrect mixture and dosing. So it is important to prevent the entry of the air and other contaminants into the cartridge. So what are the adverse effects of the reuse of needles? The reuse of needles, it is very, very common in our place because of the cost. Because pen needles are nowadays it is rupees 18, 19 rupees per needle. One needle they are using for 30 days, 600 rupees. The BD dosage then 1200 rupees only for the needle. So our patients are using the needle minimum 7, 10, 15. One patient who is an engineer who has been using the needle for 90 days. He tells me that no pain at all, so I am continuing to use. This is a problem. What will happen? That is glucose fluctuations, glucose variability, hypoglycemia, all those things are happening. So needle should not be reused. According to the fitter guidelines, one needle, one prick, throw it away. But for all the practical purposes, we have tried. One needle we can use up to 3 pricks. Some patient 4 pricks. Without any risk of hyper or hypoglycemia. See the picture, new needle and needle used 6 times. It is a electron microscope magnification. With the blind eye you cannot see it. So pain, bleeding and bruising because of the reuse of needles, contamination, infection will be there. Because the residual insulin in the needle gets crystallized, which affects the flow of the next dose. So dosage inadequacy. And also sometimes what will happen? Breaking off and lodging under the skin. So it is quite common in the many of the villages. We have to educate. And reuse of needles, one of the complication is lipohypertrophy. And very, very important thing, in a family, both the husband and wife, sometimes girlfriend, boyfriends, both sharing the same syringe. So we should not allow it, because syringes, vials, cartridges, all those things are meant for single person use only. So they should not share the syringe. And also, a person with the diabetes has brought insulin used for his mother that was kept in the refrigerator for 3 months. He wants to use it for himself. What is your advice? Once the vial is opened, we should discard it after 30 days. So they cannot use. And also for many patients, to maintain the optimum temperature, you can use a plastic container with the cotton. This is an improvised way of keeping the insulin and syringes at room temperature between 20 and 30 degrees Celsius. Insulin and syringes may be transported to work and school in the same container. So what are the 3 timings to be followed while on insulin therapy? You have to teach, educate the patient. That is, the time is very, very important. Blood sugar testing time, 1. Number 2, injection insulin. The injecting insulin timings, number 2. Number 3, meal timings. This should be maintained pakka. Otherwise, delayed meals, no meals, etc., the patient may land up in hypoglycemia. This can be prevented by following the 3 timings. And also it is quite happening in many of the places. You have to wash hands before testing the blood sugar. Sometimes testing done without washing the hands after eating dates or handling the dates, which leads to high blood sugar reading in glucometer. That patient going for hypo with the insulin treatment. And one common thing is type 1 diabetes, type 2 diabetes, pregnancy, GDM requiring insulin. So insulin in pregnancy and special conditions. So special conditions, diabetic people with the jaundice, hepatitis B, HCV, HIV. Here you have to use gloves to avoid needle stick injuries. Whereas skin diseases like vitiligo, psoriasis and eczema, healed lesions, one can give insulin. Pregnancy, first trimester, no change in the insulin site or technique. Second trimester, you can use the lateral parts of the abdomen and can be used to inject insulin, staying away from the skin overlying the fetus. Third trimester, lateral part of the abdomen, you can use the skin fold raising method. So the patient is apprehensive, they can use the alternate sides. So and also common practice, buying the cartridge without buying the pen, using the insulin syringe for drawing the insulin from the cartridge should be avoided. Because mismatching will be there, contamination will be there. So whenever you take the vial or something like that, whenever you buy it, please check the expiry date. It is a common mistake. So cloudy insulins, NPH or premixed insulin, you have to roll gently between the two hands 10 to 20 times for insulin crystals to mix uniformly with the solution. Otherwise, there is differential concentration, hyper or hypoglycemia will be there. Do not shake the vial because air bubbles will appear on the top. Shall I take one more minute? So how to remove the air bubble? Tap the air bubble, tap, air bubbles will come up and it can be removed. So whenever we write, we have to write very legibly, mention it. You have to put UNITS. Many patients, many doctors, they write 20U, the U like a circle, it seems to be 200. Sometimes in our Madurai Medical College, some 30, 40 years back, it happened. 20 units they have written. It looked like a zero. Staff nurse, that's a first year student, given the 200 units, the patient went in for hypoglycemia. Biggest problem, you have to educate very clearly to our patients. So insulin should be given half an hour before meal. Educate the patient. Routine conventional insulin 30 minutes for the hexamer to convert into monomer for absorption. So mismatching of the insulin syringe vials, insulin dose calculation. Yes, we need to educate in our clinic, society, Lions Club, Rotary Club, in all the places, whenever you get time, as a group discussion, educate the people, and we should tell them, if we don't find time to educate in our clinic, we have to educate our staff members, dietitian, diabetes educators. In turn, they sit with the patient, family members, so that the fear will be nullified. So thank you very much for the patient listening. Thank you.
So this is excellent, very practical errors we actually see. I think many of these mistakes are still happening. So recently I had to quote one example in my hospital itself. Even the corporate hospitals, many people. In fact, many of the hospitals doesn't know other than actrapid as insulin.
Exactly.
This is one of the unfortunate thing I can say. Second thing, recently what happened was one patient was getting only 2 units, 3 units because he was on the high risk of hypoglycemia. But still he was going severely hypoglycemic, and it happened that he had to be shifted to the ICU. Then the reference was given. When I go and re-looked at everything, they were using the cartridge and the 40 IU syringe. So this was one mistake is still happening, and then we had to educate the whole hospital that this is not the way. And so many of these mistakes are still happening. I think we need more education, and some education mainly in the hospitals, I think. And ICU, unfortunately, they still use only actrapid.
Before we move on to the very passionate topic, I'm very impressed by what the next speaker has done. At Disha, we do a green initiative. Somehow 3 bouquets have sneaked in. Otherwise, we usually have these spots, and we encourage delegates, pharma delegates, anyone else who is interested to take them home and nurture them. So after the talk, all of you will be free to take it. We'll be very, very happy if it happens. There are a few more in the hall B, and some more in the, we are about, I think 350 pots are there. So that is one thing, and then I'll hand it back to the anchor, and a fantastic presentation as usual, Dr. Muralidharan. And thanks to both the chairs.
Once again, congratulations to Team Disha for excellent deliberations, which have been organized in a meticulous way. Thank you once again.
Thank you so much, doctors. I would request the speaker and the chairpersons to move towards the selfie area for the group photo and the memento.